So we're going to move on to polypharmacy, the 7 steps. So for most of my career, I've based in Scotland, which you've probably guessed from my accent, right? So as a clinical pharmacist in Scotland, we were all encouraged to use the polypharmacy guidance from day one. So for those who don't know, Scotland has the polypharmacy guidance, which goes through something called the 7 steps. It's been out since 2015. So those of us in Scotland have been using it for a very long time. It's a great tool to enable truly targeted polypharmacy management for everyone, not just for those in Scotland, because it's structured, evidence-based and supported by practical resources. So at the heart of the guidance is the 7-step patient-centred medicines review. So step 1 is to define the therapeutic objectives. We want to identify the essential drugs. These are the medicines this patient needs and must continue. We are then going to check the ongoing need for the other medicines. Are they still needed? Are they still required? So those that are not essential, right? Number 4 would be see if the therapeutic objectives have been achieved. Obviously, you know what these therapeutic objectives are because you would have defined them at step 1. And then step 5 is safety. So we want to review, is there possible interactions? Has the monitoring been done? What are the monitoring requirements? So if you don't know what the monitoring requirements are, refer to SPS, the BNF, all these tools, all these resources have advice on what monitoring is needed for each medicine. Also the electronic, the EMC, Electronic Medicines Compendium, which has sorry, I know as pharmacists use a lot of abbreviations, so they have like SPCs for each drugs, which is basically what the drug company has to complete these for each drug that they've put through for licensing, and it will tell you what monitoring is required for each of these drugs. And that's accessed through the EMC, the Electronic Medicines Compendium. So when you're reviewing the safety, the interactions monitoring and adverse reactions. And then number 6, because we all do work for the NHS, we've got to look at cost effectiveness, right? This is why we have to adhere to formulary prescribing, because every ICB, every health board, every PCN has a formulary which recommends the drug that you should be prescribing first line, because not only is it effective for that condition, it is the most cost effective. And then number 7 is when you're speaking to the patient, you got to identify and address the risks to adherence. What might stop the patients taking the medicines as prescribed, right? So compliance is a big issue, and we have to have that conversation with the patient about, is there any particular reasons why they might not be taking the medicines, or they don't want to even start taking those medicines. So what makes the guidance so valuable is that each of these steps is backed by 3 really useful reference sections. So if you're looking through the polypharmacy guidance online, the first set sets out the key considerations for each step. The second step maps these steps to relevant therapeutic groups. So there's actual tables in the guidance. So these tables will map out the steps to relevant therapeutic groups. And the third step is also a table, dives deeper into using well-established tools like Start Stop and DQIP into one integrated resource. So for example, it'll break down therapeutic area and give you sort of a medication assessment tool for each. So I'll give you an example. For example, it breaks down PPIs and it asks, it's letting you know this could be a caution in some cases, and saying if long-term treatment is necessary, ensure treatment does not exceed usual maintenance doses. It reminds you to use the minimum dose required to treat symptoms, and it's also got a caution and for those who might be experiencing C. diff, Clostridium difficile, those who've got osteoporosis or hypomagnesia, because long-term use of PPIs, especially at higher doses, the treatment doses are come with risk of having calcium deficiency, which can lead to osteoporosis. It can lead to having calcium, B12 and magnesium deficiencies, and it can cause C. diff in patients. So this is what I mean about the different tables within the polypharmacy guidance. It reminds you what you need to look at for each drug group and what are the cautions of those drug groups. So when we're working through the steps, for me, it's not just about ticking boxes. We're applying a consistent, comprehensive framework designed to make our reviews robust, targeted, and clinically sound. So we're going to move on to a case now, and looking at polypharmacy in someone who's got moderate frailty. So I know that earlier on Mo was talking about frailty and how to score frailty. So for this patient, Janine, who is 96, she's got moderate frailty. And we're going to show you how to apply the 7 steps for the same patient at 2 different points in their frailty journey. So when we first meet Janine, she's 96, living in her own bungalow with 4 carer visits a day. She's mobile, okay, that's important, around the house with a 3-wheeled walker. And at this stage, we scored her as having moderate frailty. So our therapeutic objectives are about maintaining function, independence, and preventing exacerbations. So if we were to take her through the 7 steps, what are we looking at? We are going to keep essential drugs because we want to maintain her function. So what are essential drugs when we're looking through here? Are they things like her anticoagulant for AF, her heart failure medications, her nutritional supplements because she's still eating and mobile. But we also want to try and prevent hospital admissions. So we might start questioning some long-term preventatives in her case. For example, whether a statin is still meaningful at this age, or whether her iron is still needed if her anemia has resolved. We want to talk to Janine. Is she compliant with all her medications? Has she got any issues with her medications? Does she find she's getting any side effects with any of her medications? So obviously we're going to be looking at cost effectiveness as well as part of the 7 steps. But what if things changed for Janine? So if we fast forward and Janine's circumstances have changed dramatically, she's now in a nursing home with severe frailty. She's hoist dependent, incontinent, and just been admitted with aspiration pneumonia, and is on a pureed diet with feeding at risk. So now when we apply the 7 steps, our therapeutic objectives shift. The focus moves away from prevention and life prolongation towards comfort, symptom control, and reducing pill burden. Medicines like her statin, her anticoagulant, dementia drugs, and even some of her heart failure medicines may no longer align with her goals of care, especially with swallowing difficulties and high aspiration risk. It's exactly the same patient, but the stage of frailty changes the conversation completely. This is why the polypharmacy guidance and the 7 steps are so powerful. They give us a structured way to review, and they keep us focused on what matters to this patient at this point in their journey. So this side-by-side view is important because it shows how the same structured approach, the 7 steps, can lead to very different decisions depending on the patient's stage of frailty, goals, and current priorities. Have we got any comments? Just stop in there for a second.
No comments yet.
Okay.
And no questions yet.
Okay. Great. So we're going to now move on to another case here where I'll get more of the audience to participate. So here we've got Mick, an 87-year-old gentleman. He's presented following a fall. He was mobilising from his bedroom to the toilet when he fell and had a long lie on the floor before help arrived. He denies losing consciousness but does recall feeling dizzy just before the fall. No vertigo reported. His past medical history includes hypertension, ischemic heart disease, type 2 diabetes, heart failure, chronic kidney disease, and benign prostatic hyperplasia. He also has a long-term catheter in situ. Here is his medication list. So we've got your Benadryl, your lisinopril, isosorbide, metformin, diltiazem, tamsulosin, and finasteride. So thinking about this presentation, could this fall have been related to an adverse drug reaction? Possibly. What are the likely culprits in his drug list?
Keep them coming on the chat. Isosorbide, people are saying lisinopril.
Yeah, possibly.
Tamsulosin.
Yeah. Absolutely. Yep, definitely. I'll talk through more of these later on, but any others?
Bendroflumethiazide.
Yeah.
Also, Lawrence says finasteride.
Interesting. Yeah.
Diltiazem.
Yeah, so possibly nearly all of them could be could have been a culprit and maybe caused his fall. But what further information would you want to gather from the history, either from history, the observations, or examination? What investigations would you request? What further information do you want?
So some answers are some blood work, blood pressure.
Yep.
Kind of lying and standing, I'm assuming.
Yes. Yep.
That's it so far.
Okay. Any particular type of bloods? What are you going to ask for when you're asking for bloods?
So Jenny says we need to establish whether they are compliant with their medication.
Yeah, absolutely.
Zoe mentions more kind of history-related things. Does he normally feels dizzy? What his baseline observations are, his BMs.
Yeah.
Kind of looking for more peripheral things.
Yep. Yep, absolutely. And carry on.
So Emma says some bloods include, depending on the duration of the lie or how long they were on the floor, you could do CK. If you're particularly concerned because of the fall, you can also do a CT brain or CT head.
Okay.
Some blood examples include Usenease, FBC, HbA1c,
yeah,
liver function test, and CRP.
Yep, absolutely. That's exactly what I was getting at. So yes. And the other, finally, we're looking at this, his list, and we're thinking to ourselves, can any of these medications, do any of them absolutely need to be stopped, or do some need to be suspended, or dose adjusted today? So we've kind of identified some of the medicines that could be possible culprits. We've kind of discussed whether this could be an ADR, and And we know that falls are common presentation of ADRs, and they can be a result of polypharmacy, but obviously we want to consider other differentials. So this is about keeping an open mind and not jumping straight to blaming the medicines. So other important differentials in mixed case would include arrhythmia or other underlying cardiac disease, visual impairment, maybe, yeah, confusion or sensory impairment such as diabetic neuropathy. And yet, that's some of the tests that we'd absolutely want to be doing. In terms of investigations, we want to be doing the basics, the lying and standing blood pressures to check for postural drop, ECG to look for bradycardia or arrhythmia, full blood count using these to check electrolytes and renal function, and CRP if we're considering infection. So let's have a think. If this was your patient, which of mixed medicines would you review first? And what would you be looking for if you're thinking about amending them? So if we were to run it through our 7 steps framework, I'll help you a little bit here. First, what are mixed therapeutic objectives? What are we trying to achieve with each of these medicines? And we want to think about which of these are essential drugs that we can't stop without risking harm.
So bendroflumetazide and isosobide mononitrate.
So you're saying those are essential drugs?
Oh, I'm just answering what's on the chat. So I assume.
Yeah, so yeah, I mean those could be possible causes of the dizziness, postural drop, or
Oh no, sorry. Claire's clarified. No, review these first as to whether they're
yes,
needed or not.
yes, exactly.
Sorry,
So
Claire.
yes, you're right, Claire. These could be causing some of the symptoms. So yeah, bendroflumetazide, Claire, yes, could be stopped if we're seeing postural hypotension. Lisinopril, I'd keep if possible because of its cardiovascular protection. Isosorbide monotrite, well, it could come off if angina isn't an active problem, so yes. So that would be step 3. We're looking at the ongoing need for each of those medicines. 4, have the therapeutic objectives been achieved? 5, are there safety issues? We're looking at interactions, the need for monitoring. 6, what about cost effectiveness? It's the one that a lot of clinicians actually tend to forget sometimes because it's not really the first driver in the acute review, but it's part of the bigger picture. You can come to that one last sometimes. And step 7 is risk to adherence. Could complexity, side effects, or physical difficulties with taking his medicines be playing a role? So yeah, absolutely. Here's how we applied the 7 steps to mix medication list. Bendroflumetazide, this is a thiazide diuretic. So in someone with postural drop or low blood pressure, the potential harm, which could be falls and dizziness, can outweigh the benefit. So here we'd consider stopping if his BP is low or if there's clear evidence of postural hypertension. Lisinopril, as I said, this one we generally try to keep because it has both primary and secondary prevention benefit in cardiovascular disease. So unless there's an adverse effect or low BP that we just can't control, it's worth protecting. Isosorbide. If angina isn't problematic, the need for long-acting nitrate is questionable, okay? It can contribute to postural symptoms, so we'd consider stopping this. It's one that's often forgotten about, actually. I see patients who've been on isosorbide for many, many years, and now they've got older, they've not actually had angina pains in many years, and it's a drug that we can certainly come back to down the line when patient circumstances change and think, is there still a need for it? Metformin. So there's no immediate indication to stop this just now, provided that his renal function is stable and there are no GI side effects. So you've got to really watch with renal function with metformin, and you're always looking at creatinine clearance and not just eGFR when it comes to adjusting doses for drugs in patients with CKD. I don't know if Mo mentioned that earlier. So if his renal function is stable, we would continue the metformin. Right, diltiazem. This could worsen postural hypotension. It can cause bradycardia. It can also lead to fluid retention. So we'd stop this drug if any of these issues are present. And tamsulosin, a few of you actually did say this. Alpha blockers are notorious for lowering blood pressure and causing postural symptoms. Okay, so tamsulosin, you've got to really remember it could be a possible culprit. And in this case, it's probably the most likely culprit for his blood pressure drop. Finasteride. Is there really a strong indication to stop here? I couldn't really see a strong indication to stop this unless there's another reason. It's not generally linked to acute falls risk. So you can see not everything needs to be stopped, but some drugs stand out as likely contributors to his falls risk. So as I was saying earlier, the aim isn't to deprescribe everything, but to identify the highest yield changes that will make a meaningful difference to safety without compromising disease control.